Welcome to another continuing professional development online podcast from the Royal College of Psychiatrists. My name is Raj Persaud and I'm a consultant psychiatrist based in London. And I'm talking today to Dr. Madhav Goyal, who is an assistant professor at the Division of General Internal Medicine at Johns Hopkins University. And Dr. Goyal is part of a large team of researchers based at Johns Hopkins who recently published a fascinating paper entitled Meditation Programs for Psychological Stress and Well-Being, a Systematic Review and Meta-Analysis. And this has been published in the Journal of the American Medical Association, Internal Medicine. Now, this paper has attracted a lot of media interest and a lot of interest generally in the world of medicine. So, Dr. Goyal, let me first of all start by asking you, tell me a bit about this interest. What have people been interested about in this paper?
Well, meditation has been around for centuries, and there have been a number of clinical trials done over the last 50 to 60, 70 years trying to elucidate what are the benefits of meditation for various outcomes. And while many of the studies have found positive effects, it hasn't always been clear that these were placebo effects or something that were above and beyond the placebo. So the purpose of our doing this study was really to assess whether there was a benefit to meditation programs that went beyond the placebo effect.
And you looked, according to the abstract and the paper, at something like 18,753 citations, but ended up including only 47 trials in the study. So you excluded a lot of studies. Why did you do that?
The first reason was part of our focus. So we were mainly focused on psychological outcomes. So we didn't look at things such as blood pressure or cytokines, and that was one of the exclusionary criteria. The second reason was that we were looking at rigorously conducted randomized trials in which every randomized trial also had a control group that controlled for placebo effects. And so that was another large reason why trials were excluded.
Let's talk a bit about that, because a lot of people would find it difficult to understand why you're excluding trials that don't include a proper placebo control. There's this well-known effect in medicine known as expectancy effects. Just going to see the doctor, turning up at a clinic, seems to have an impact, seems to help people get better. And you need to try and find whether the particular treatment in question, like meditation, has a specific effect, as opposed to a non-specific effect and just making people feel more hopeful about the future? Is that one of the reasons why this is so important?
Yeah, I think you've described it well. So, for example, when a person goes into a drug trial and they're given a placebo, that placebo can have an effect based on the individual's beliefs and expectancies that this pill is going to help me. And so that's the reason that placebos are included in drug trials. The same phenomenon occurs in a behavioral intervention where someone receives a behavioral intervention such as meditation or something else, and they're going through the program, they're interacting with the faculty or the trainers, and all of these things give them the belief and expectancy that this program is going to help me. And so this placebo effect has healing powers. We recognize that. It's not a bad thing, but it's just something that we like to compare our treatments to make sure that they are doing more than just what our own beliefs may be doing.
Now, another reason why you excluded a lot of studies was something to do with the fact that these studies were observational studies. And what that seems to mean in this particular context is that the trial didn't randomize people, didn't allocate people into a meditation condition or a placebo condition. It looked at people who'd already chosen meditation. Why is that important? There seems to be some important effect of you choosing something influences the outcome.
Yeah, so there are influences based on people who self-select into a particular program. So if I am someone who likes to go to the gym regularly, then I will feel that I'm likely to report that that gym has helped me in many ways. So the same goes for anything else that I might be interested in. So the one good way of telling whether a program is helpful is to take all of those people who have volunteered for a particular program and randomize them to either that program or to some other type of program.
So the randomization bit's kind of important in investigating whether something's really works or not.
Absolutely, it's very important, and it's very important that trials also describe how they have done the randomization. I wouldn't say many, but there are some people who feel that they have randomized people, but all they've done is just assign them every other person to one group or the other, and those aren't properly randomized studies. We did come across a few of those that we wound up excluding.
So one of the key findings of your analysis is that, in fact, there's a lot of very poor quality research being done on meditation, so we should be very careful about drawing conclusions about the efficacy of meditation, and we should look carefully and only look at high quality trials.
Well, that's true. The problem is that when you have a field that's as nascent as meditation in terms of an academic field, there isn't much money to study it, and the initial trials that are going to be done are all going to be pilot studies that don't have the resources to properly randomize and follow people in a blinded fashion. So that's just a consequence of the way that meditation research had to start out. It's a new field of research. But as it has evolved over the last few decades, it's become more and more rigorous. I think people are recognizing that the randomization and the blinding and so forth are important issues, and we're starting to see more and more of these types of studies.
Okay, so one possible interpretation of the key finding of the key result is that meditation does work in some situations, but it only works relatively moderately and only works in some conditions, and only certain kinds of meditation work.
Yeah, so we should keep in mind that the meditation studies that we reviewed were, although there are many different types of meditation, we were only able to find mainly two types that have been studied in these rigorous RCTs. One is mindfulness meditation that's largely based off of Jon Kabat-Zinn's MBSR, mindfulness-based stress reduction program. And the other is transcendental meditation. Both of them provide, one could argue, comparatively small amounts of training. That is, for MBSR, it's about 2.5 hours a week of training over 8 weeks, and for TM, even less than that. And I think in our group, some of us were probably surprised with what we found and others weren't. I was surprised that despite these relatively small, quote-unquote, doses of meditation over fairly short periods of time, we were still seeing consistent effects on three very common outcomes: anxiety, symptoms of depression, and for pain. And the interesting thing was that when we looked at anxiety and depression, the populations that were studied were quite varied. You had people with low back pain or fibromyalgia, or that were caregivers of elderly people, or had some other condition, HIV, heart disease, and so forth. And no matter what population we looked at, we were seeing a fairly consistent signal that there was a small benefit to anxiety and depression. In some cases, a moderate benefit, but mostly a small benefit. And I think that is a fairly strong finding, that we're finding consistent effects. They're all in the same direction, roughly the same magnitude, and for these three outcomes.
But I thought the other thing you were saying in your paper is this small to moderate effect could be obtained by taking an antidepressant. In other words, there was no superior efficacy of mindfulness meditation over taking an antidepressant.
Yeah, so there were very few studies, only one or two studies that really compared the meditation program to a pill. And so it's hard to comment on what would we find if we had more studies that did head-to-head comparisons. When we look at the magnitude of effect for depression, for example, we find that the magnitude of effect we're finding for mindfulness meditation on symptoms of depression is about the same as the magnitude that other reviews have found for the effects of antidepressants among patients that have mild levels of depression. And so that I think is an interesting finding.
You said you were surprised that there was such a consistent effect. Other people might be surprised that there wasn't more effective, because it's been sold quite a lot these days. I mean, maybe sold is a strong word, but mindfulness meditation or mindfulness techniques are seen as a kind of new wave in psychology, replacing cognitive behavioral therapy. So it's very fashionable or in vogue, the mindfulness approach in psychology, if not mindfulness meditation. It's being almost peddled as a panacea for all ills, some might say.
Yeah, I think that would be misleading, and we certainly did not find it to be a panacea for all ills. We do find that it has some benefit, and it's in three fairly common conditions: anxiety, depression, and pain. And that the magnitude is not a large magnitude, it's a small improvement. And the questions that are unanswered, one largely has to do with this issue of dose. That is, meditation programs were never really conceptualized as a treatment for health problems. They were a path that one follows to improve one's awareness, insight into their own lives. And that path of awareness and insight has many benefits, one of which may be a benefit in psychological or physical health. And so because the studies looked at such short-term outcomes, short-term follow-up, with fairly little training in novice meditators, people who had never meditated before, it's unclear whether if you train somebody for a year and you did it in a more rigorous fashion, whether they would have greater improvements, or whether we might start seeing improvements in many of the outcomes that we currently are not seeing with these short-term studies.
You make an interesting comment about that in the paper, where you say that meditation could be seen as a kind of lifelong journey, and maybe randomized controlled trials are somewhat unfair to an approach that's seen as a lifelong journey.
Well, so certainly for a lifelong journey, but we do very few studies that are able to look at very long-term outcomes in randomized trials. But you could conceive of a randomized trial that followed people for 5 or 10 years and looked at the effects over that time period. That would be very informative, rather than these 3 to 6 month outcomes.
Now, I know that you may be reluctant to comment on this, but it did seem to me from reading your paper that transcendental meditation, which has a kind of marketing push behind it, and maybe more so in the 60s and 70s, didn't seem to me in my reading of the paper to do as well as mindfulness meditation. But you've commented on, when we discussed this before this broadcast, that there were very few head-to-head trials. It was a dangerous statement to make.
Yeah, so we were doing two main things in this review. We were looking at the magnitude of effect on these outcomes, and we were the second thing we were doing was we were grading how confident we were about what we were seeing. And so that was what we call the strength of evidence. And we graded our confidence or the strength of evidence on a 4-point scale. So we had high grade, moderate, low, and insufficient. High grade means that the findings are in trials of very good quality. All the findings are consistent. The magnitude of improvement or change is roughly similar, and the findings are statistically significant. And we would conclude that the results are so conclusive that we don't think any further trials in this area are going to change our opinion or going to add any more information. We didn't have any high-grade evidence, high-grade conclusions for either positive or negative outcomes for any meditation program. So that's telling us that we do need more studies. Now, we had 3 moderate level conclusions for anxiety, depression, and pain for mindfulness, and the rest were low to insufficient. And what low to insufficient really means is that the study's results are conflicting or are in poor quality trials, or there are other issues that lead us to say that we need more study in this area. And so we could have conceivably come up with a high-grade conclusion that TM does not improve anxiety. That is not the case. We had low to insufficient evidence, which is just saying that we need better quality trials to evaluate these particular outcomes for this particular meditation program. So TM, I think, historically has focused a bit more on biologic outcomes, which were not a focus of our review. But among the studies that were included, we did not see any consistent signal for any of the outcomes we evaluated.
If someone is listening to this who may be suffering from anxiety, depression, or pain, or maybe some other condition, is thinking of trying meditation, what advice would you give to them?
So I think that the average person going through a mindfulness meditation program could expect small to moderate reductions in symptoms of anxiety, depression, and stress. Anxiety, depression, and pain. So if this is something that they are interested in, it's certainly something that doesn't require taking a pill. It doesn't come with any known side effects, and can be used in conjunction with whatever other therapy they are taking. Over time, they can kind of figure out what role, more of a role or less of a role, they want this to play in their lives.
We've been talking about transcendental meditation and mindfulness meditation, but we haven't really defined what those terms mean. They're quite difficult to explain. Would it be possible just to give a brief explanation of what they are and how they differ from each other?
Sure. So mindfulness meditation is derived from Vipassana and other related Buddhist practices, in which a person is taught to be aware of their thoughts, their breath, their sensations, their emotions, and other various aspects of their lives. And in being aware of these different aspects, they are taught to be aware of them with a particular perspective. That is, it's a non-judgmental, accepting, non-reacting perspective. That is kind of the basic idea. Transcendental meditation involves first using a mantra, and the mantra is repeated in a way that allows a person to eventually reach some subconscious spaces of their mind. This is just a vehicle that's used to increase their awareness. Both of these, keep in mind, both of these explanations of these different types of meditation are overly simplistic. It's hard to give a clear understanding of what these meditation programs are, because meditation is really an experiential process. I could explain to you what swimming is, but you'll really only know that when you jump in the pool and try to swim. And that's much the same with meditation.
And what about doctors? What advice would you give to doctors, particularly family practitioners, general practitioners, family doctors, in terms of prescribing or recommending meditation?
So I think clinicians should, one, be prepared to talk with their patients about the role that meditation programs could have in addressing psychological stress, particularly when the symptoms are mild. I think that physicians should be aware that these programs are secular, that anyone from any background, religious or cultural background, can come and practice them or learn them. I think those are the two things that I would say to clinicians.
So I want to close by asking perhaps a slightly mischievous or unfair question. There were a large group of researchers besides yourself that were involved in doing this research. I wondered how many of them might have been practicing meditation themselves before taking part in this meta-analysis, and how many of them changed their minds about meditation, how many took up meditation, or how many abandoned it. Would it be possible to ask that question as a result of looking at the data?
So let me think. A minority of our researchers were actual practitioners. That was a small minority. So I would say there was, I am a meditator. I practice Vipassana meditation. It's I guess you could call it a form of mindfulness. And one other physician meditates, and then one other physician does a lot of research in it, but I don't know how much she actually meditates. So there are only two or three of us that I could say actively meditate, as far as I know. In terms of who would have started meditation, after we completed the project, I have not asked anybody this particular question, nor has it come up. So I don't know if it changed anyone's mind about meditation or not.
Because some people would say that's the acid test, in a sense, when doctors take part in research, whether it has an impact on their actual behavior beyond the statistical significance stuff.
Yes, but I don't know how many of them are suffering from anxiety, depression, and pain.
Okay, good answer. Thank you very much. So a module test is available with this podcast on the Royal College of Psychiatrists website for you to obtain your continuing professional development certificate if you are interested in obtaining that. This test will ask for an access code. The code for this podcast is meditation. Thank you very much indeed.